Hi everyone, I'm Dr. Ahmed, Winslow Health Centre.
I'm Dr. Fari Ahmed, also from Winslow Health Centre.
And today we're joined by Mark Widgery from a company called Medlink Solutions, who we've been using for a long time now, almost as long as we've been using Accurix, and actually a company that's made a massive impact on the way that we run our practice. So, hi Mark, how you doing?
Hi guys, very well, thank you. Yeah, thanks very much for having me join us. Pleasure to be here.
Very welcome. Yeah. So you've got new products in the pipeline. You've got new developments, and I think you've just relaunched the company, haven't you, recently?
That's right. Yeah, we've been around. So myself, I'm a portfolio GP, and my business partner Lawrence is a partner, and we both work at Ensham Medical Centre in West Oxfordshire. And we've been around since 2019. We actually launched the business, and up until fairly recently, we were very focused on online reviews of long-term conditions. That was what we did, and what we've now and happy to share with you guys today is some major developments as part of particularly our EMIS integration that allows us to automate recall.
So, just for some of our viewers who haven't seen Medlink before, can you just summarise the product so far?
Sure. When we started, there was very little that happened online. We were all doing everything face-to-face, as had been done for a long time. And we felt that there was a real niche. There was some online triage tools for acute problems, but really very little or nothing at the time that dealt with long-term condition reviews. And we thought that was quite an appropriate market, a clinical scenario for online reviews. So we built a product that did that initially just for a few basic conditions, ran it in our own practice as a trial, and actually ended up with clinicians who were patients of ours at our practice, who worked at other practices, actually contacting us directly, having completed our asthma COPD reviews, saying, "Can we have this at our practice? This is really good." Yeah. And they were actually our very first clients. So it developed organically from there. And once we'd run the trial in our own practice, we then decided to make it available to colleagues. And although we run a business, we're both GPs, we're the directors of the business, and we want to market this to colleagues. And by GPs for GPs, and that's genuinely how we've always run the business.
Brilliant.
So I've got some slides to share. Shall I start doing that just now? Yeah. And can you guys see?
Yeah.
See our just bear with me a second. Let me just. Okay. So. Right. There we are. So Medlink started, as I said, as a primarily an online review system where we're now live in 200 practices, about 2.2 million patients. We've gone through the assurance mill. We've recently got onto a framework, Crown Commercial Service there, and lots of NHS digital requirements for assurance as well. The background to Medlink was really all about, as I said, online reviews of long-term conditions, and that was what we did up until we relaunched the business essentially in September at the EMIS NUG, which is where we got to see you guys as well. And really Yeah, absolutely. Yeah, we've obviously met online before, but not in person. It's always really nice to meet people who we've met on video calls and on phone calls at the conferences. Essentially, we've recently gone live with EMIS API integration, which is the automated integration, and that's what everyone's been asking us for from the very beginning. Up until before that, we were sending emails into your DocMan, typically DocMan EDT inbox. They were inputted into your standard DocMan workflows, how most practices worked it, and the data that we gathered from patients for their reviews online was inputted directly via templates. Now, clearly, that's a fairly manual process that we all wanted to automate. And so we worked with EMIS and NHS Digital to have access where we can write that data into the record automatically, which we can now do. What became very evident when we started doing that was that actually, as well as writing into the record, we can actually pull data out of the record and read the patient record. And that's really become the basis for our automated recall process. And this is just an image which just gives you a quick summary of the solution. So essentially what we're offering practice is a fully automated, integrated multimorbidity recall service. And what that means is we can automate the searches, identifying which patients need review. We can automate the invite process in terms of sending those. The reviews themselves can be carried out online by patients in their own time on their own device. The one part of the whole process that requires input from the practice is the clinician assessment, and we'll look at a bit more detail at that. And then finally, we can code all of that data into the record without any admin input whatsoever. So this has fundamentally changed the focus of us that we have as a business and the utility that we provide for practices. So I'm going to go through each one of those in turn. Feel free to sort of to jump in. The search process is based on what's probably the most common recall process, which is based on birth month. And the way this works is that you as a practice select which conditions you want to include in the recall process. All of the Medlink conditions that fit into that natural sort of annual review are included, as well as medications, so COCP, POP reviews, as well as HRT. Importantly, we also include what we call physical checks. These are elements of the review, so bloods, foot checks, urine ACR, that can't routinely be done remotely by patients, that need input either from clinicians in the practice or for samples to be sent off to the lab. So that's the search process. And what we do then is within each patient's birth month on a particular day, we analyze their record and we download it. So we run this all in. We don't give anybody EMIS searches. What we do is we download the record of each individual patient and we do a full analysis of that record, and we then identify all of the relevant conditions for that patient, all of the physical checks they need, and for each patient we then build a personalised, bespoke multimorbidity online review for that patient. So no more trying to work out which patient gets sent which review. Every patient, it has a personalised review that is built specifically for them and for their needs at that time. All of that logic is based on QoF business rules. So we recreated the complexities of the QoF search process. But instead of putting out a list of patients to you, what we're doing is doing that on each individual patient and building up a clinical picture of what they need. Those are customizable. We know that each practice runs things slightly differently. So, for example, you can see here in our settings page whether patients in different categories in a care home, housebound, end of life are included or excluded from the automated recall process. So that's how our search function runs. So we can actually run your recall, and I say this to people all the time, do you want to run your recall? You never have to touch another EMIS search again. We can run it without doing that, without all of the complexity and unpredictability of EMIS searches, which we're all far too familiar with.
Don't know what you're talking about. EMIS.
Yeah, exactly. So and it's a different way of looking at things. It's about building up a clinical picture of each individual patient rather than producing a list, and that's the brand new part of what we've done. We've always had a multimorbidity review, but instead of before patients sort of selected which conditions are relevant, now it's built for them and specifically for their needs. Wow. So then we automate the invites. Sorry, go on.
No, I'm just trying to get my head around that. So that's so for each individual patient, instead of filling in lots and lots of templates and sending them lots and lots of forms, it's built for that particular patient, and that comes in as a review online that they do, and then exactly. The patient does it, and then all the relevant codes get directly inputted into their patient records.
Absolutely. And even more than that, all of the additional elements that need to be done, like bloods and foot checks, as we'll see in a minute, we're helped to organize that process as well. Wow. So yeah, the idea of this, that the pattern is patient has a one-stop shop, and patients always find it frustrating when they're bombarded by multiple different conditions, especially if they've got 3 or 4 different reviews that are needed. So the aim was to incorporate that into a single sitting for the patient, but then when it comes into the practice, it is both auto-coded, but it also can be separated out and sent to the relevant clinician or team, and that's important for the way these things are managed in the practice.
So, Mark, can I ask? So, do you run a separate dashboard then in Medlink, or does it is that so, or is this running just in EMIS?
No, so this is running separately and I'll show you some. So what you saw earlier on, that list of exclusions, that's within our web application. So the way this is set up, to be honest, we don't have that much to show for recall, because basically you have a 30-minute setup in front of our web application, hit go, and you can essentially forget about recall. All the searches and all the invites are run automatically. Wow. And so we've got a dashboard that shows you the progress, and we'll come to that in just a couple of minutes. And that allows you to see where manual input is required, and that's necessary for a small proportion of patients. But essentially, the idea of this is what I think people really want is to make the decisions about how recall is structured, and everyone does that slightly differently. And then once those decisions are made, for that process to happen in the background without any regular manual intervention, and that's what we've built.
Okay, brilliant.
So once each patient's had their, we call it their recall data set, they've had their analysis done, we then send them an invite. That's either by email or by SMS for patients who don't have those, and that's pulled directly out of the EMIS record. If they don't have an email address or a phone number available, we actually place an automated voice call to patients and ask them to contact the practice. That's a small proportion of patients, but they can still be given their link if they want. And this is typically what it looks like. So you can see here, instead of being a particular condition, this is going to, this is just one of our test patients that we've used, with a link to their annual review. So that link that you see at the bottom of that invite is specific to that patient and can only be accessed by that patient, and is specifically for their needs depending on the analysis of the record that we've done. And importantly, as those invites are sent, we then code all of that data directly into the record. So this is what we call a recall status consultation, and this is written into EMIS at the time of invitation. So you can see there the various elements of it. We've got all of the what we call physical checks that are required. So this patient needs a blood pressure done, a urine ACR, and also a blood test and a foot check. We list the conditions there and why the review is due. So, for example, if diabetes had already had a review within this fiscal year, it would be excluded, and it would say, and you can see there for mental health, review completed within the fiscal year, and actually gives you the code and the date that it's done. So it gives you as a clinician actually a snapshot of where the patient is in terms of their recall. It tells you how they were invited and the link that they have. So all that data is written in, and importantly, the invites are coded, and we then send a repeat invite 2 to 4 weeks later. So the process will fulfill the QOF requirements. Every single one of your patients is invited for every single one of their conditions, if necessary, twice within the fiscal year. It will fulfill that whole requirement. Obviously, if they engage and complete the review, then we don't send them out repeat invites, but it will fulfill all of those requirements. Does
it link into your appointment book?
So So we'll come to the arranging what we call the physical checks, and there are ways of automating that process in for the patient. So the aim is that the patient both does the online review and then is actually given instructions which are configurable by you as a practice of how to book an appointment if one is necessary. Yeah. And that's part of the process. So we see that happening in one of two ways. One, the patient engages online and then is given instructions, which you'll see in a minute. The second is the patient receives their invite, but actually might not want to choose to engage online. We're always going to have patients for whom that's not appropriate or they don't want to do it. And they will then contact the practice, but you've got here a quick summary of exactly what's needed. You can give them the link. If they do have a mobile number, you can send the link to them if they want to do it online. It gives you a quick summary as a practice of where things are and puts in the record exactly what's going on in terms of your recall. Okay. So that consultation is written in without any admin input at all. It's a fully automated process. Farah, you were asking about a dashboard. So this is what things look like. This is just dummy data. So this is obviously the fiscal year. It shows so this practice started their recall process, the automated recall process, in September. What's happened is that the previous months that were passed have been scheduled for catch-up. So if you start at partway through the year, you can actually schedule those patients to be caught up during the QOF year. And within each month, once the month is complete, you can click this download CSV button, and that downloads a spreadsheet which contains all the data, all the invites that have been sent, and all the patients who've been invited, and all the conditions that are relevant. But most importantly, also contains a list of patients who weren't part of the automated recall. So these are patients who you've excluded from recall because you've said you don't want them to be part of the automated recall process, and they may need some input. The only other patients who aren't part of this process is where there are no contact details available for them, which is a tiny proportion of patients. And including those patients, they may need a letter to be sent if necessary, or there may be some other way of contacting them. But those are the only patients who can't be part of the automated process. So that's the process for the dashboard that you mentioned. That allows you to see the progress and where things are. It gives you numbers there of how many patients are going to be analysed in each month. And we're building out the dashboard at the moment, so there will be opportunities in the future to see exactly how many have been invited and engagement levels as well. So that gives you a kind of overview as a practice. We'd also been asked, and this is a work in progress, to be able to run some of the later months earlier. So March is always run in April to avoid end of QOF year, but some practices like to run January and February earlier as well. Everyone runs things in slightly different ways. And so there'll be a kind of, instead of the catch-up button, there'll be a run this in advance button, just to give you control.
But primarily, is it birth month recall that you use.
Exactly. It's So this is so in each patient's birth month, but obviously there are nuances to that in terms of nobody wants invites to be sent out on the 25th of March because trying to get anything done is a nightmare. So that's one of the examples. And obviously we want to give practices control about how they manage the recall process as much as is possible within that basic framework. So that's the downloadable section, and really, what we're anticipating and what we've seen within our client practices is that, staff who were managing recall, the only role they have left to do is to actually look at this downloaded spreadsheet and identify whether these patients need any further input. Has a massive impact just on admin capacity, actually.
Mm.
So that's the sort of automated searches and invites process. And bear in mind that at this point, other than the initial setup, the practice still hasn't actually done anything regular. There's been no work involved. This has all been running in the background. And then you have the patients review themselves. So you can see here, and you guys are familiar with this, these are the reviews that are available within Medlink. We've split them now into the left is everything that fits into the natural annual review process. So all of the long-term conditions, pill checks, severe mental illness, learning disability. There are some Medlinks, so cancer care, which is sent at a particular time, anxiety and depression, which isn't always sent annually, NHS health checks that are sent at particular times that still need to be manual. And all of the manual invites that people have been sending via, mass email, mass text message, and individual text message can still happen. That's still part of Medlink. But we anticipate that the multimorbidity automated invites will replace a large proportion of that process.
And also, because some viewers might be confused between the Florey type of review and the Medlink type of review, in what way is Medlink different?
Sure. So I think, Florey's came about actually after Medlink started. And I think one of the things that we've always felt is that what we didn't want was for our clinical reviews to be a kind of quick tick box exercise. Your ACT's done, tick a box, and that's your asthma review done. There may be a role for that in terms of triaging patients initially, but we always felt that we needed much more than that to be able to interact with our patients meaningfully. So I think one of the ways in which we differentiate ourselves is that our reviews are more clinically thorough. We try to make them an engaging and meaningful experience for patients, and actually I'll go on to the next screen because you'll see some of that. We have images and video inside there that interacts with the patients, and we also build in enhanced services, NHS digital weight loss service at the moment, for example, which allows revenue generating potential for the practice as well. So those are probably the two big differentiators from other things like Florey's, which are focused on online reviews and long-term conditions. So this is what happens. Patient essentially logs in using their date of birth, and then you can see here the list of conditions for each patient. So rather than being lots of individual things coming in, their individual conditions are listed. The introduction is just a kind of consent section. And then there's an additional bit. So obviously what we've had to do is remove anything from the particular individual Medlinks that's repeated, because nobody wants to answer the same question twice, and then put that into a separate additional section. So blood pressure readings, if they're relevant, weight, height, smoking, and alcohol status. So the aim of this, although it's going to be a longer review for the patient, it's actually a much better experience because it's one-stop shop, once a year, covering everything. And none of this, I send you the asthma last month, can you please now fill in the HRT review or whatever the clinical scenario is. So that's the idea for patients. And exactly what I was just saying, we've tried to make this a really meaningful, engaging content. Clearly, we've got to get the balance right between, if it's so short, it's not very meaningful clinically. If it's so long and in depth, the patients give up the will to live halfway through and you just don't get them to complete it. And so we've tried to maintain that balance and but to make it something that's both useful for sharing information with patients, in this case, a video specifically for their type of inhaler, and also gathering the relevant information from patients. And then at the end of the Medlink, we not in every Medlink, but in most of them, we ask this sort of question: anything else you'd like to add, so sort of free text? And then how would you like to proceed, or how would you like to complete your review? And what it gives patients is the option. We're not saying we don't want to see you. What we're saying is, okay, we've gathered all this information. How do you feel about things? Are you happy with how they are, or do you want to speak to somebody? And what we don't want is to have that sense of, to patients, we don't want to see you, but ultimately we do want to give them the option of having the remote review. We don't guarantee it because it might not be appropriate. And so that's the way we've built the system. And I think patient feedback has been really positive in that sense of, oh, this is great. I can do it at my own time. I don't have to wait for an appointment and, mess around with childcare or whatever it might be. And if I do want to speak to somebody, I've got the option to express that and to arrange follow-up. So that's the way.
the feedback from our patients has been exactly that. You know, that it can be very inconvenient for them to find time to come, and actually they'd just rather do it online for a lot of them. Absolutely. So it's been really good for that.
One of the things we've been really surprised at, actually, clinically, is just how many people with mental health conditions have expressed that. I mean, clearly some are just never going to want that, but actually the freedom to sit in your own home on your phone or your tablet and answer your questions, think through what's going on, express your concerns, is just so different from the pressure of sitting in front of, you know, one of us. And with the best will in the world, people know that we're busy. They know that they have a limited amount of time, and so they often feel quite rushed, and this just gives patients a kind of breathing room to do that. So actually, you know, some patients who want to interact in person can always do that, but this gives patients, actually, we've been surprised at the positivity of the feedback from patients there. So you mentioned the appointment booking section. So this is kind of where we come into that. So I'm a patient. I've completed all of my questions, but I also need, in this case, a blood test, foot check, and a urine ACR to be done as part of my my diabetes review in that case. And so what we then do, we allow you to customize the instructions for your patients. And if you do use online booking services, so through the NHS app or Patient Access, for example, those links would surface here. And you can give specific instructions to patients for exactly how they should arrange those what we call physical checks. And so the simplest is just calling a practice and booking it, but there may be other ways of actually going about that. And so the idea is that you configure those instructions, and we're analyzing the record, and you actually get to specify how recently do you want these. So you can say, I want an A1C when my diabetics are seen within 3 months, but actually I'm fine with a foot check within the fiscal year. You decide on that what we call recency level. And what that means is that you then know that when your clinicians come to those responses, all of that data is going to be available, including these physical checks. So you can configure those instructions for patients. And when the data comes into practice, we'll see in a minute, it's kind of held in a pending part of the inbox until those physical checks are completed, so the data is all available. We tried to work hard on making our system as meaningful as possible for patients. You can customize, so that banner across the top there is the banner for our own practice. That's one of the partners at my practice, who's, you know, recognizable face standing in front of a recognized building. It's a 15-second video saying, welcome to our online system, hope you find it helpful. It's a very simple thing, but what it reassures patients is that what they're seeing is legitimate. There's no way this is a scam, and it just increases patient engagement. And that's the case for branding. We allow you as practice to customize the signposting. So where you send patients to, you can see the list there: smoking, alcohol, weight loss, psychological input, and then general lifestyle advice. So it allows you to put in local links to your services, which just makes it a more meaningful interaction for patients. We do also incorporate, in this case, the NHS Digital Weight Management Program. And this is something that sets Medlink apart. We understand primary care and the way these services are structured. And so you can turn this on inside the settings, and so appropriate patients for appropriate BMI and appropriate diagnoses will be consented for the NHS Digital Weight Loss Program, and they'll come back into the practice. We're making that clear, and so all your secretarial staff need to do is send off a referral letter for those patients and code that. And we've actually had practices cover the entire cost of Medlink just by the enhanced service revenue generation. And then we also incorporate elements like social prescribing. It used to be funded, that funding is now ended, but it's still a useful service. And so it allows you as a practice to customize that for your local services and make good use of that for your patients. So that's the online review themselves. Clearly, the system is not wedded only to online reviews. The patient receiving an invite and told their review's due. Some of them will be arranging an appointment to do that. But for the vast majority, actually, they're happy to engage online. I think that was one of the big changes that we all saw during the pandemic. It was the willingness of our patients, particularly actually our more elderly patients, who in the past would have been, you know, adamant that it must be done in person. Actually, just a much greater willingness to engage online. You know, when one of my patients, who's a 95-year-old lady who's bedbound with RA, you know, got a letter, scanned a QR code on her tablet, and filled her RA review out really helpfully. And then I had a follow-up phone call with her. You know, it just showed me how far our patients had come in terms of the willingness to interact digitally.
So we've got quite a few very silver surfers who have got no problem at all.
Yeah,
and they love it. So yeah, absolutely.
Yeah. So what we come to now is the sort of fourth part of this cycle. So bear in mind, you as a practice have still done nothing. This has all been run in the background. The searches, the invites, the review. So we now come to the only part of the process that we as a business cannot do on your behalf, which is getting a clinician in front of some information about a patient and making a decision. And so what we tried to do, again, with the process here being trying to maintain the flexibility for the practice, is to give you options. So the first option is what we call the Medlink inbox. So that a patient's responses come into the inbox within our system, and so your clinicians then log into that system and look at that. And that lends itself really well to large volume Medlinks. Asthma, we see it really used a lot for asthma, COPD, pill checks, particularly with clinical teams managing that. We know, however, that some clinicians, particularly those who might be dealing with a smaller volume, just don't want a new inbox and they don't want to deal with a new workflow. And so we also have the option of what we call auto-code and email. Now that's if you, as you've been using Medlink, you'll be familiar with this, and anyone who's been using it for a long time. Up to now, we've been sending the PDF documents into the email, come into DocMan, and they get workflow to the relevant clinician by your workflow team. Exactly that process still happens, but the difference is instead of your team manually entering that data in a template, it's automatically coded at the same time the email's sent. So it's a very low kind of significance implementation, because you just carry on looking at your DocMan. There's no need to log into a new inbox, but there's no need for your staff to sit in front of those documents and code the data. It's all automatically written into the record, and you can control at an individual both type of review level and also an individual clinician level which one of these two options is used. Now, the Medlink inbox, although it takes a bit more setting up, and it does have some additional functionality which we hope makes it more useful, and we'll look at that briefly now. So this is what the inbox looks like. You can see here a patient has completed. You can have patients completing multiple different conditions, and so you can see there this is actually we just blocked out the names there. But if a patient has completed multiple conditions, they will all come up there together, but they can all be assigned to different clinicians or to different teams. The important part here is what we call that physical checks column, the second column from the right, because what that's showing for the mental health here is that there is a physical check still pending. Because what's really frustrating as a clinician is to come to a patient where you have 90% of the information that you need to make a decision, and then have to think, oh, if only I had the BP, if only I had the A1C, I could get things done and get it completely finished. So the aim of this is those sit in the inbox, and what we do is we every day, multiple times a day, we check the record to see if those physical checks have been completed. If the A1C code's in there, the foot check, the ACR, all of those different elements. And they show then as completed. So what you can do as a clinician is you can filter out the pending stuff so that you only see those that are completed. So what you know is that you're coming in as a clinician to a full data set for making a decision. And that's the critical piece of this. So that's how the inbox looks. And then once there is a Medlink response that's relevant to you, you load into it. And this is how it appears. You can see there at the top, you've got the physical checks themselves. This is obviously for a diabetes review. And so you've got there on the left the results that have actually been pulled out of the record for this review that have been done. In this case, this would be soon, become complete soon after those dates. The blood pressure has been completed inside the Medlink.
I'm just telling Ferry we've got this. Need to show it later on. Yeah, absolutely.
And you can see all of the relevant, and these are all the QOF data, as well as the information on the left, their results for this review. We actually pull out the previous results as well, and we're not going to recreate EMIS, and so you can see everything, but we want to give the pertinent information in that section up there. So that's the physical check stuff, and you can see there how recent it needs to be. So you can actually decide as a practice. Your diabetic nurses might say, well, I want things slightly more recent than that, and you can control that those settings inside it. And then you've got. This is essentially the data that you've been looking at for many years on the PDF documents that came into DocMan. It's exactly the same data, just in this format. So these are the patient's responses here on the left. Those blue ticks means it's coded data. And again, we pull data from the patient's record as a comparison there on the right, which just allows you, with the dates there, to see whether there's been any significant change or whether the patients maybe made an obvious error in some of their input. So it just allows you to look at that data and make a decision about their clinical needs. And then over here on the right, we call the workflow action section. So that allows you to send messages to patients by SMS or email. We check consent codes in the record as well. It allows you to add a comment for the record, and that's written then into the record but doesn't get sent to the patient. This is a diabetes example, but for example, there are particular condition-specific elements. So the asthma action plan, which is a QOF required element, can now be edited within this menu and then is automatically attached to the patient's follow-up message and sent to them. And it just allows you as a clinician to come in, see all the data, make a decision, and then follow up with the patient as appropriate. And then once you, once you finish that, you click File to Clinical Record. And at that point, all of that data, so the patient's coded response data, your message to the patient, your comment for the record, and the documents themselves, the summary document and the asthma action plan, if that's relevant, are all written directly into EMIS. There's no admin work at all. So if you use the Medlink inbox, your admin staff will no longer ever see any Medlink work coming in. It just completely bypasses them, because the only scenario where the interaction that's needed is in the inbox itself. And so once the patient, the clinician clicks on that, this is what happens. So this is a diabetes Medlink. So this is written into the record at the time of being seen inside the inbox by a clinician. All of the coded data is there, the attachments are there, the clinical comment that you can see, and then the message to the patient and details of that, as well as the review codes themselves. So all that data is written in, and the beauty of that is a single consultation that kind of completes the review cycle for the patient. For that condition, it might be there's some follow-up needed, and the clinician arranges that, and that's very clear from the consultation itself. So that's what the advantage of the Medlink inbox, allowing you to both have the pending information to go into know full data sets there, messaging and clinical comment. But for all of the reviews, the autocode and email is still available. And what we find tends to happen is practices will set things up, start going with autocode and email because it's very easy to use. But then it's worth training staff, particularly when they're dealing with large volumes, things like asthma, COPD, pill checks, to train their clinical staff and clinical teams to use the Medlink inbox because of the additional functionality. And this is the document. You'll recognize these from your own DocMan. And these are the formats of the document that come through when we send the document through by autocode and email. It's got patient details, all of the patient's responses, and the appropriate codes there on the right. So that's the kind of PDF copy of the inbox view that we were looking at earlier. So when we talk about when we're trying to sell this to practices, why use this? What's the significance? Well, I hope and particularly with the new automated recall, there's a potentially massive impact on admin costs. We've actually not been, I say, we sort of relaunched this in September, so our data on that is still fairly limited. But our own practice, we've had a number of members of staff whose job was to run EMIS searches, run recall campaigns. I mean, it's a very, even for the most organized practices, it is still a very manual and a very time intensive process. Yeah. And it gets quite. Yeah. I'm sorry.
It can be hit and miss as well.
It can be hit and miss, and so really, what we're saying to practices that, particularly practices that have struggled historically to really get to grips with recall, is spend half an hour. We're actually happy to sit on a Teams call like this with our clients, set up recall for half an hour with them, just to explain things, hit go, and at that point you can essentially forget about it and let it run in the background. We include all of the communication costs in the basic price of Medlink. So all of the email, SMS costs and the automated voice calls is included. And the clinical capacity, which is what we've always seen for many years in Medlink, just making online reviews more efficient and allowing you to have a sort of task-based workload for your clinical staff. It releases significant clinical capacity. And then finally, the revenue generating, which we mentioned, the NHS digital weight loss, which is, if you activate it, is built into the system and can generate significant revenue. I think one of the significant ways in which we want to differentiate ourselves from lots of other services is that we can actually offer that full package, automated recall, direct code entry for EMIS web practices at essentially the same price that it's gone up from 10p to 11p per patient since we launched this back in 2019. Wow. So this is we want this to be as accessible as possible, and we know what the fiscal situation is in primary care. And so we want to make this as accessible as possible. We actually offer discounts for PCN contracts and IC contracts and ICB level as well. And you, just looking at that graph, this is a kind of average numbers. You can see the cost of subscription there against both the revenue generating potential and the release clinical capacity. And as I say, we don't really yet have good data on the admin saving, but I think we can all imagine, members of admin staff in our practice who could very easily be redeployed to multiple other useful roles if they didn't need to be sort of manually running the recall process. We still offer a referral scheme for practices to spread the word, and we offer new clients a 3-month free trial, get it set up and running. What we're encouraging practices to do right now is to get it set up, and they can start running the recall now, but to get it set up in place for the new QOF year, because it makes sense to kind of, to start it, to get that ready to go in April. And so straight away, that's turned on, and so you never again need your staff to think about EMIS searches, campaigns. It's all run in the background for you. And if anybody who's listening is interested, that's just our website there. It's got lots of more detail about how the system works, and that's just our info email address there as well. You can get in contact with us. As I say, we can get the free 3-month trial set up really very quickly for interested practices. Registration is a very straightforward process. We've got all of the information governance documentation that's required. DPIA is the biggest document, and we've got a very comprehensive document that's been seen by multiple ICBs across the country. So I mean, there's always the possibility of IG putting barriers in place, but in most places they've already seen this work, and so it's a very straightforward process. And particularly as the integration is now signed off by EMIS and NHS Digital, that really helps with the assurance process.
Brilliant. No, it was a question that I'm asking everyone these days, because I think more and more people are quite worried about all the information governance stuff, and the ISO 27000 and all of those. Yeah. So you've got all of those, haven't you?
Yeah. So I mean, we've got all of the necessary assurances, and that NHS Digital have provided, have required of us, and we've got all the documentation absolutely to go along with that. And I think the important thing to mention there is that we're not a medical device that's doing clinical decision making. That's never been our remit, and we don't see that as probably ever being our remit, to be honest. What we want to do is be an efficient data gathering tool on your behalf from your patients, so that you can do the one bit that we can't do. So we automate as much as possible and present that data to your clinicians to be able to make clinical decisions for your patients. And that's always been the way that we sort of run the business.
Great. I have some questions, if you don't mind, Mark.
Of course, yeah.
So one of the things we try and do a one-stop annual review, but we link it then to our medication review. So I imagine that's not going to be too difficult to do with your system.
So we, for all of the long-term conditions, barring a couple where it's not. So almost all the long-term conditions include a medication review, which is structured around so we do have a standalone medication review as a Medlink, as you're aware, but most of them do include then a medication review, and we ask patients, all the standard questions about compliance, concordance, and recreational drugs. It's based, so for patients for whom it is relevant, a medication review will be done. As part of that annual review process. So the idea is that you've got all of that information available, because the last thing you want to do is to be sort of going through it all and then thinking, well, hang on a second, there's this one bit left as well. Now there clearly are other clinical scenarios that lend themselves to an annual review process. And as we develop the product, that we will sort of build that out more and more. We focused initially on having a complete, comprehensive, making sure all of the QOF elements are completed for the annual review.
Does it automate resetting the medication review in EMIS, or is that asking for too much?
Unfortunately not. We're also integrated with Vision, and Vision does allow us to do that, actually, and we tried with EMIS. Essentially, the reason is that the API, which is the name of the program that allows our system to talk to EMIS in the back end, restricts which bits of EMIS we can control. So to give you an example, we can gather email addresses from patients and we can give them to you. What we can't yet do is actually put them into the email slot if it's been updated.
That happened to me. I sent out 16,000 or however.
It's
update your contact details, and I expected more communicated, so we're working through those. It's still a good exercise to do.
But maybe it might be another EPR
Well, there might be another EPR coming soon.
Yeah, no, I know we talked to you guys. I mean, and to the extent that we're able to integrate with the clinical system, it's natural for us to do that. So if EMIS made that particular element where we could update the medication review, my suspicion is though that EMIS seems to have, because it has a single medication review date and then it has a medication review date for each individual drug. Like EMIS, it just seems to sometimes go a bit overboard, and so I'm not sure if that will be feasible, but ultimately it's a very straightforward, minimal manual step. And the important thing is having all the information gathered to be able to make that decision.
Great. We found it probably one of the most useful things in the years that we've been using it with the medication.
Yeah.
Excellent.
And just sorry, what about
leses?
Leses, can you set it up for some of your like local contract monitoring?
Oh, we spoke about this, remember?
Yeah, absolutely. So the answer is
did one. Yeah.
The answer is potentially yes. I mean, what we need to be able to do is it depends on two things. The number one is how many Medlink clients are asking for that, and if it's just one or two, the answer is going to be probably not. If we've got a whole multiple PCNs or a whole ICB signed up, and they say there's this element that we really want to gather, then absolutely. And to be honest, quite a lot of the time those elements are relevant to the rest of our clients as well, even if they're not necessarily funded to do that. So as much as is possible, I always don't want to sort of overpromise and underdeliver. So we can't promise that every single request is receives a positive response, but as much as is possible, we want to add to it. So as an example, we had the NHS Digital Weight Management Service. We had a lot of practices come back and saying, okay, well, some patients aren't eligible for that, but we want to be able to gather consent for referral to other services. And so we added elements to the weight module to be able to do that.
Brilliant.
Thank you.
And your cost there compared to other similar products is very competitive.
I'm always slightly unclear on how much I'm allowed to say commercially about others, but yes is the answer. Where we've looked at those who sort of market automated recall systems, it is I think I had one client mention to me like it's like 1/5 or 1/6 the price of something else that we're looking at. So we always feel like, yes, we're running a business, but chatting with you guys, I'm talking to colleagues, and that's always how we've wanted to run the business, and we're able to to commercially to be able to do that, and to offer all of the EMIS integration and that without. So and people often say to us, is the price going to increase? And of course it is, because prices of everything increase. But are we going to suddenly come to you and say, oh, it's not 11p this year, it's 55? Well, no, we're not going to do a bait and switch to to our clients. So and I think practices are already concerned that we're trying to kind of lure them in, and then you end up with an unexpected large bill, and that's not how we ever want to run our business. And
it's not, from my personal experience, how you guys have behaved. It's been one price for a long time now, and actually it's gone up by 1p. I've got it. I just need to have the time to set it up.
Of course.
But you guys would help with the setup, because it seems that.
Yeah, absolutely. So what we've said to practices is, particularly with recall, and then the actually getting the coded data into the record, that setting up the EMIS link, clearly needs some time. We've got a really comprehensive setup guide, but there is some nuance to it in terms of how you run things as a practice. And one of the things we found really helpful is just sitting on a Teams call like this with typically a PM or an ICT manager, whoever the most appropriate person is, and just talking through it and getting it set up for you as a practice. And we're really happy to do that at the initial setup stage, and then we've got a support team who can come in and help with implementation. I think one of the things that we anticipate and hope with as recall becomes more widely used is, because it's automated, once you set it up, essentially there is the only ongoing requirement is about a 10-minute job once every 3 months. I mean, it really is like it's less than an hour's work a year to maintain it, just to manage the list that's used. And so it really is a very straightforward process. So what we want to do is help practice get that, over that any sort of initial hurdle of setting it up. And because we want to give practices control, it's not a click and turn it on, and there are elements that can be configured. So yeah, we're more than happy to meet via Teams and help with that.
And you mentioned earlier on about it's priority is that it's date of birth date that you run the recall around.
Yeah.
But if so, and you kind of mentioned it's better to wait until April before you implement it. But if you were to do it now, you'd be doing something called catch up. Is that,
yeah, so it wasn't so much it's better to wait. It's more that what you want to do is have it in place for April. So yes, if you started that process, I mean, it's being almost beginning of December now, isn't it? And oh no, it is the beginning of December. Sorry. And so absolutely. So what you can do is run catch up for all the previous months. Now, obviously, there's a word of caution to a practice. If a practice has been, frankly, not doing any recall for 9 months, for whatever it is, 9 months, and then turns it on and does catch up, you're going to have 12 months worth of recall in 3 months. So that has the potential. But we had a number of practices turn it on who've already been running, whatever the recall system is, and as long as they've proportionally been doing it, whether it's month of birth or a different setup,
and I suppose I suppose you could turn on specific groups instead of the whole lot.
Absolutely. Oh yeah, you can choose. I mean, clearly the most powerful way of using it is to turn everything on and then everything's done in one go. But yes, you can turn on individual conditions and run that in the recall as you choose to initially, and then just get your staff familiar with using it, and then so what we've got a number of practices doing is doing that and trying it out, and then turning the full system on, or turning on in its entirety in sort of March or April time.
Brilliant.
Great. That sounds amazing, actually. I know one of the other things we do use it for is when I start people on antidepressants, and this is separate. I do a time and a Medlink to go to them in a couple of weeks. So I can then decide, actually, do I need to see them that week, or can they wait for the end of the month? I know people do it for
it's amazing.
Blood pressure.
Pressures, everything.
Stuff.
Yeah,
so
absolutely.
Yeah.
And so what kind of things are you going to be working on in the future?
That's the question. So here's where I don't want to. My development team would lynch me if I say too much here, because if we start using the word straightforward, we get we get people giving us nasty looks. But I mean, I think when we look at recall, there are clearly lots of clinical scenarios outside of the QOF recall that just lend themselves to annual review. I mean, it's just the ones we talked to have been annual TSHs, a patient on levothyroxine, patients who are on ACE inhibitors and ARBs who need an annual renal function checked, anyone on a statin who might need an annual LFTs or cholesterol, depending on the setup. So there are lots of different clinical scenarios that would lend themselves, and because we're now not just looking at data gathering using sort of online questionnaires, but also arranging physical checks automatically, blood tests and other things, there is the potential for adding in, we've been in discussion with a GP about a CKD review, which as well as we're asking some questions, but primarily be around gathering that data. So that's one of the things that we're looking at in terms of potentially adding to the recall process. Exactly what the timing is going to be of that, I don't want to give any sort of commitment, but those are the sorts of things that we're looking at. And then the other one, which is actually slightly more complicated, and Farah, you mentioned it earlier, is that while we do medication reviews for patients who have a condition, there are a number of patients for whom we need a medication review who don't actually have any of those QOF conditions, right? Yeah. But at the same time, if we just say, well, you've got repeat medication, send a medication review. I mean, I'm pretty sure nobody wants a medication review of the patient who's got repeat Cetrabin, right? It's not what we're about. And so one of the things we've started looking at, and which we're hoping to develop, is a way of identifying which, actually using the BNF grouping, which medications are significant enough to require a medication review for a patient who otherwise wouldn't have one, versus those, and actually giving you as a practice a degree of control over that as well. So that's a potential future development of an automated medication review that would happen for patients for whom they wouldn't get a medication review because of a specific condition. We'll watch this space.
Yeah, no, absolutely. Sounds really good. So many things happening all over. There's lots of developments going on now. So if a practice was thinking about moving forward with Medlink, what would your advice be?
So the two ways to get in touch with us. The one is the info@medlinksolutions.co.uk website, email address that I showed you earlier. We've got an expression of interest form on our website, which just gathers some information. What we often then do is we call people back, have a chat over the phone. If people want, we'll sometimes organise a demo. It's been really helpful to do that at a kind of PCN level, and sometimes when people have a PCN meeting to kind of do a demo very similar to what we went through today. Some practices just call us and say, great, let's sign me up, let's just go for it. And we have it's about a 15-minute Yeah, exactly. 15-minute registration process, and you can have all the material in your hands. And for those who are confident with with managing the setup, we're happy to help. But for many of our clients, they've just had somebody who's run through the setup process and configured it for their practice. And then that you have the full functionality for 3 months, and then essentially we have your list size, and so we calculate a 11p per patient plus VAT. And we send you an invoice normally about 2 months into the trial, and that's then payable by the end of the trial to continue. And then the other thing I didn't mention was you have a referral process, particularly for practices to refer other colleagues on. That's how most of our new business comes to us. We can market it with blue in the face, but you guys or any of our clients talking to colleagues and saying you should try this. And if a practice signs up for registers for a free trial, then we add a month to your annual subscriptions of practice up to maximum of 6. So essentially, you can get sort of 18 months for the price of 12.
Excellent.
Maybe we should put a link in the blurb at the end of the video. That's all right.
Yeah, absolutely. And I mean, if people who've watched this, mention you guys, which would be great, then absolutely that would be our pleasure.
What I've really enjoyed is the reports that you go back stating how much time you've saved
and how many. They actually target your Medlinks as well, because you go, hang on, why is nobody using that one?
Yeah, absolutely.
You go back and see,
So there you have it. Medlink Solutions going to the next stage now in their development. I've been using them for a long time now, and along with people like Archirix, Medlink Solutions are one of our health tech heroes, one of the most used products that we've been utilizing in primary care for a long time now, and really, really helpful. It just works, and that's how tech should be in primary care. Yeah. Mark, thank you so much for coming on.
Thanks very much for your time, guys.
I'll look forward to speaking to you soon about setting all of this up.
Yeah,
absolutely. Great. Yeah, we'll be at a number of conferences in the near future if anybody who's listening wants to come see our booth as well. And it was a pleasure to see you guys again. And look forward to catching up again at some point soon.